Right. Okay, thank you, sir. I'd like to thank Dr. Ravi Nair and Dr. Srinivas for giving me this opportunity to be here. So I think I'll keep my presentation very brief and short and just highlight on a couple of points that I think will be more relevant here. So yeah, we're running late by 2 hours or so. 3 hours. Oh, I'm sorry. All right. So I kept the objectives for the talk is to just introduce on what is vestibular rehabilitation therapy, and I thought I'll demonstrate the VRT a bit. I'll see if I can do that, and who responds to VRT, and will VRT really improve the balance in the vestibular situations. So vestibular rehabilitation therapy is a specialized form of exercise-based therapy to treat both the primary and the secondary symptoms of vestibular disorders. The primary symptoms being the dizziness, the loss of balance, and the visual problems. So, and the secondary being the nausea, the fatigue, the strength, and the lack of endurance. So the primary issues, everybody has touched upon it many times. So I'd like to take a minute or so to talk about the strength and lack of endurance in these situations. So most of this population who have the issues of the dizziness and stuff would always restrict themselves to being little inactive. So over a period of time, what happens is their exercise tolerance levels would be too less and their strength would become too low. And their ability to do the activity for a period of time, say even for 10 minutes or so, would be too much limited. That's when we say that the endurance is limited or decreased over a period of time. And the other most chronic complications that we see are a couple of experiences that I have with some of the chronic patients has been like, because of their primary problems, they do not move their neck at all. When they don't move their neck at all over a period of time, because fear of the dizziness and fear of falls and stuff like that, they have restricted joint mobility, neck mobility. Because of that, there will be severe tightness of the trapezius muscle and all the neck muscles and the interscapular muscles as well. So we've seen chronic trigger points that are being observed in these populations. So they come to us. There was one situation where the patient has visited multiple different domain doctors. Like one patient was referred to me by a neurosurgeon. Imagine their primary problem has been the vestibular problem. So because of the secondary impairment being the neck pain and lots of trapezius spasms radiating up to the upper cervical region. So she visited the neurosurgeon. So he said, go to the physiotherapist and stuff like that. So when we try to deal this patient in treating of these, we cannot move the neck. We have to treat these things. We have the primary symptoms come in the way. When we try to handle the primary symptoms, the secondary symptoms were coming on the way. So I thought I'd like to share this with you because if we can handle these the primary and the secondary symptoms in the earlier stages itself, it will be easier for us to rehabilitate the patient so that they get back to their functions. So therapy may be very brief for certain situations like BPPV, which we are not going to talk about now, are more involved in complex conditions where we have, for example, vestibular hypofunctions. All right. Have I jumped off? Right. In vestibular disorders, the deficit is permanent because the amount of restoration of vestibular function is very small. Whatever is left is very little. So the main focus of vestibular rehabilitation therapy is finding a compensatory means so that maintains the balance of the individual or so that they can get back to their functions. So thereby compensating the neck movements, compensation can be done by using the other sensory systems. The other sensory systems that are left to maintain these functions are the visual systems and the somatosensory. Somatosensory being the proprioceptive and all the other sensory receptors which have been briefly or in long explained in the morning sessions as well. So, compensations, what are the ways of compensatory trainings? Here I'm not talking about primarily in the BPPV. So, following BPPV also we do the vestibular rehabilitation therapy, whereas other conditions we can go with these vestibular rehabilitation therapies. There are three main methods of exercises which are followed, which is the habituation exercises, the gauge stabilization exercises, and balance training exercises. So we need to identify which patients fall into which category of the exercise sessions. So it's not necessarily that all the patients should be given all forms of exercises to train them for their primary impairments or the secondary impairments. So habituation exercises will be given to those people who have issues with complaints of dizziness with some movements. So they can have, we need to identify which are those specific movements that actually elicit these impairments. So you need to identify those specific movements and then get them to do that. So the habituation, it's simply just that we try to take them into the same position where these symptoms are elicited. So I give this example, I give this kind of explanation to the patients. Suppose the patient is turning his neck and then he gets his symptoms. I say that I don't ask him to do the full rotation of the movements. I would say that when you move it, when you get the 10% of the symptoms, stop it there and then come back type. So when we make these movements repeatedly over a period of time, the habituation gets better. So when the patient, if your objective is to get there with the, where the symptoms are not there, initially I would ask him to move. If it says that 10% of the symptoms are there, ask him to come back and repeat the same maneuver, same movement. So over a period of time, the range will be getting better types. The other systems, other neuronal systems in the body takes over the function of the vestibular dysfunctions. So that's how we do the habituation. So some people might complain of problems with lying to sitting up, side lying to sitting up. So we can train the same activity which is actually triggering the symptoms. So that you give this symptom of the problem by 10 to 20% of what actually is causing the patient's problem. If the patient is having problem with turning, and if we train the patient to do the habituation exercise in the anterior or posterior aspect, we are not going to treat him. We need to really clinically screen what is actually triggering and then prescribe whatever is relevant in there. Then gauge stabilization exercises, I don't think we need to really talk on that much. Here again, we try to get them to do all of this exercise with low doses which the patient can tolerate. If you go on full on with the exercises, they might get really psyched up. They might not want to get back to you at all. So we need to moderate the exercises in a way that the patient can tolerate those exercises. And then the balance training exercises. So the balance training exercises where we have the vestibular, this visual and the proprioceptive, somatosensory playing a role in maintaining the balance. So we have to target or challenge the two remaining systems, the visual and the somatosensory systems, because vestibular system is already compromised. So we need to design exercises that will challenge mainly the somatosensory. So the somatosensory can be challenged with various forms of exercises. So for example, the one simple example that we can advise to the patients is standing at home. If you have to prescribe the home exercise, stand on the pillow, which is a cushiony surface, or the sofa seat, which can be detached from the sofa. We can ask him to take it out and place it on the floor and then make him stand on that. When we make the patient stand on unstable surface, they are challenged to maintain the balance because the proprioceptive systems are challenged more. So then if you have to challenge them more, we take away the visual input. We ask the patient to close their eyes and then stand on the normal surface first. If he's able to maintain the balance, the vestibular system, the proprioceptive system is being challenged more, it starts working more. So the compensations can happen only by means of challenging the proprioceptive, the somatosensory systems. So we have various modifications that can be done to challenge the somatosensory systems. So I would have loved to demonstrate all of those, but having the constraint of the time, we would not really like to do it as of now. Strength, flexibility, and endurance training. So this one, I highlighted this point especially because this is one thing that generally is ignored by all the domains of medical practitioners with vestibular systems, because over a period of time they give up everything. I just told the same point earlier, the strength, flexibility, endurance. It's not just the strength and flexibility of the neck muscles, the strength and flexibility of the entire musculoskeletal system will be compromised. So we need to really put them back on the track by giving them general exercise also, as is primary and secondary symptoms were getting as they get better. Right. So who responds to VRT? So not everyone with vestibular dysfunctions do respond to VRT. So there has been good success with those people who have been having BPPV. Even following BPP also, after repositioning and all that, sometimes there might be a need for vestibular rehabilitation therapy, but sometimes you might not really need it at all. So vestibular neuritis, labyrinthitis, vestibular hyperfunction, stroke, TBIs. We see lots of patients with stroke and TBI also with lots of dysfunction with vestibular dysfunctions, where we try and accommodate most of the time we miss it, but still sometimes we do tend to handle patients with TBI and stroke as well with vestibular rehabilitation therapy. And post-surgical correction of vestibular deficits. And progressive disorders like Meniere's and vestibular migraine may not necessarily be really helped, but yes, with the medical management, there might be some amount of benefit that we can expect following the VRT. Then, the last point is, will VRT really improve the balance? I just thought, I had my new venture is the smiley, it's my Renew Life logo. I just put that up there. Okay, yes, it does really improve the balance in the vestibular rehabilitation with vestibular dysfunctions. Thank you all.